To document the margins and extent or borders of the papillary adenoma, the circumference of the adenoma is initially traced with the papillotome. The bile duct and pancreatic duct are then intubated one after the other with the papillotome. This is intended to make access to the pancreatic duct, in particular, easier after the resection. Injection of 0.9% sodium chloride under the papillary adenoma is carried out. The sodium chloride is mixed with indigo carmine to provide better demarcation of the margins. A good lifting sign is a prerequisite for subsequent resection. The blue dye helps demarcate the margins better. The papillary adenoma following injection of 7 milliliters 0.9% sodium chloride. The borders of the adenoma are well visualized and a complete resection can be attempted. Resection of the papilloma with a braided resection snare, diameter 15 millimeters. It needs to be ensured that the complete adenoma is grasped with the snare in toto. After the resection, the specimen is immediately retrieved with the snare before being moved further into the duodenum and then withdrawn into the stomach. The resection site is then inspected for potential bleeding sites or perforations. Immediate cannulation of the pancreatic duct. The aim is to prevent post-interventional pancreatitis following the resection and the expected swelling. For this prophylactic measure, a stent is to be placed in the pancreatic duct. A 5 French single pigtail stent, 4 centimeters long, is now placed over the guide wire that has been introduced to ensure that the pancreatic duct is not compromised if there is post-interventional swelling or bleeding and to minimize the risk of pancreatitis.